A new treatment for patients is dropping soon. Remember the name, Baxfendy, also known as Baxdrostat. Baxfendy is coming soon. Baxfendy is almost here. Stay connected to Baxfendy. Visit baxfendyhcp.com. That's baxfendyhcp.com. Sign up to receive upcoming updates on Baxfendy.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, Cardio Nerds. I'm Jenna Skowronski, chair of the CardioNerds Heart Failure Council, here for our 7th episode in Advanced Heart Failure series. Today, we highlight an especially important topic when caring for our patients, and I'm so excited to hear from our guest in what's sure to be a meaningful discussion. In today's episode, we'll explore the importance of palliative care's involvement throughout the heart failure spectrum, but especially at the time of referral for advanced therapies. I'm again joined by my co-chair of the series, Dr. Shazli Khan, currently an advanced heart failure fellow at Columbia, and my former co-resident at UPMC. Welcome back, Shazli.
Thank you, Jenna. Today's topic is one that's so important in the care of our patients from the time of their diagnosis and through the course of their disease. I can't wait to engage in this discussion on how to navigate these often challenging and rewarding discussions and care for these patients as their disease progresses. I'm exceptionally excited to introduce our fellow lead, Dr. Alix Barnes. Alix recently graduated from Cardiology Fellowship at the University of Pittsburgh and just started her Critical Care Fellowship also at UPMC. She completed her medical school at University of North Carolina before heading to Ohio State University for her internal medicine residency, where she served as chief resident. Alix completed a palliative medicine fellowship at Northwestern prior to starting her cardiology fellowship, making her an incredible person to join us for this episode. Welcome, Alix.
Thanks so much, Shazli. I'm really excited to be here today, and I'm so excited to introduce our expert for today's show, Dr. Sarah Chuzi. Dr. Chuzi is an assistant professor of medicine at Northwestern Medical Center and an advanced heart failure and transplant cardiologist, as well as the director of heart failure at the Jesse Brown VA. She has a clinical and research interest in shared decision-making and end-of-life care among patients with cardiovascular disease, and currently leads a novel palliative care heart failure program at Northwestern called Compass HF. Welcome, Sarah.
Thank you so much, Jenna, Shazli, Alix, and the CardioNerds team for having me. I'm very excited to be here to discuss this topic that I'm so passionate about, and this is particularly special, not only because I consider you 3 friends and colleagues, but it feels like a very full circle moment for me. My induction into the CardioNerds started about 5 years ago when I was a fellow and I was able to present on one of the case report episodes. So I've been a huge cardio nerd ever since and very excited to be here.
Well, Dr. Chuzi, we know palliative care principles can be helpful across the entire disease trajectory of heart failure. Having palliative care specialists see these patients is the goal, though with the number of patients with advanced heart failure, it's impossible for them to see every patient at the time of diagnosis. How do you define primary palliative care, and how do you incorporate primary palliative care into your personal practice?
A great question to start with. Taking a step back, I think it's really important to just define what palliative care actually is, because you'd be surprised how many patients and even clinicians carry misconceptions about this. And a lot of people, as you know, Alix, still equate palliative care with end-of-life care and just assume that it means we're giving up on the patient. So palliative care is medical care for people with serious illness that focuses on preventing and relieving suffering and improving quality of life. And as we've seen, it can be appropriate at any stage of illness and alongside curative or disease-directed treatments. And there's a lot of domains that fall under palliative care, and these include symptom management, caregiver support, decision-making, and yes, end-of-life care. But at its core, palliative care is really about relieving suffering. And so when you frame it that way, I think it's hard for any clinician to say that it's not important. So when palliative care is provided by a clinician that is not a palliative care specialist, like a cardiologist, for example, we call this primary palliative care. So when a heart failure clinician has a conversation in clinic with a patient about their goals and values, or when they prescribe medications for sleep or pain or appetite, this is primary palliative care. And in contrast, specialty palliative care is provided by clinicians who have dedicated training or board certification in hospice and palliative medicine. And I think it's really important to note that not all institutions have the same access to specialty palliative care as we might in our academic medical centers. So especially when you're talking about community settings, specialty palliative care definitely becomes more of a scarce resource. So it really is sort of a luxury to have access to this team. And so the second part of your question was about how primary palliative care can be utilized in everyday practice. And definitely earlier in my training, I really believed that every heart failure clinician should be proficient in all aspects of palliative care. Along these lines, really, I advocated for workshops and communication trainings and more skill building for heart failure clinicians. And I feel like in a perfect world, we would all be great. But now that I'm an attending, I really understand all the demands that subspecialists face in clinical practice. And I just don't think that's practical. And actually, a lot of my research focuses on the development of new models to promote better palliative care for patients with heart failure. So how we can actually do this in a way that's feasible. But I do believe that there's some basic but really important palliative care skills that heart failure clinicians should have. And these include being able to manage uncomplicated physical and emotional symptoms. So pain, depression, poor appetite, and sleep. It's really helpful if you can help manage the depression as opposed to referring our patients back to their PCP or to a psychiatrist. Recognizing caregiver burden and offering support, navigating straightforward end-of-life situations, and then really importantly, being able to have a serious illness conversation. And this is a structured conversation where we try to understand the patient's level of prognostic awareness. We provide very clear information about prognosis. We explore what matters most to the patient. And then finally, we make a treatment recommendation. And I feel like if we can do these basic things, and then refer to specialty palliative care for more complex needs, I think that's a pretty realistic starting point for improving care in heart failure.
Thanks, Sarah. I think that's such a perfect way of defining primary palliative care. And I totally agree with you that even when I was going into my palliative fellowship, I was often thinking like, am I obsolete because can't most doctors do a lot of these things on their own? But I think you're so right that with the demands of everything that you have to do as a subspecialty physician, it's impossible to be able to do it all. But if you can at least start those basic conversations, have a serious illness conversation, talk to a patient a little bit about their disease trajectory, you can always involve your specialty colleagues when things get more complicated and things are more messy. So I think we should apply this with a case. So we have Miss Heart Failure. She's a 63-year-old woman with hypertension, current tobacco use, chronic kidney disease, peripheral vascular disease, and a longstanding history of heart failure with reduced ejection fraction due to non-ischemic cardiomyopathy, who presented to the emergency department with progressive dyspnea over the last few months. She's grossly volume overloaded on exam and cool to touch. An echo shows a severely dilated LV, global hypokinesis with an LVEF of 15%, and labs reveal an elevated lactate at 5, a creatinine of 2.8, which is above her baseline of 2, and elevated LFTs. She's admitted to the CICU where a swan is placed, and she started on milrinone 0.375 and undergoes aggressive diuresis. Her lactate clears, but her wedge remains elevated and her kidneys have improved only slightly. She remains on milrinone. The advanced heart failure team is consulted for consideration of an advanced therapies evaluation. How would you utilize primary palliative care in this patient?
Yeah, so this is a tough case and also a very familiar case. I was just on service last week, and I can think of several patients that I've taken care of recently who have presented this way. So you're describing a patient with multiple comorbidities and longstanding heart failure who's presenting with cardiogenic shock. And it's not entirely clear what her heart failure trajectory has been prior to this point, but there are definitely some clues that things have been worsening over time, right? So namely her poor baseline renal function and her severely dilated left ventricle. So even without knowing details like her heart failure hospitalization history, her symptom burden, her GDMT, I'm already seeing some signs of poor prognosis. So I'm worried about her long-term outcome even before this acute presentation. So when we're thinking about primary palliative care for this patient, the first thing to reflect on is that she's not newly sick, right? This is not someone who was healthy and came in with an acute MI or fulminant myocarditis. This is someone who's probably been living with progressive heart failure for a while. And so in addition to wondering about her functional status and her quality of life leading up to this admission, I'm really asking myself, what does she understand about her illness? What's she been told? Where is she at? And ideally, this is someone who would have had upstream serious illness conversations in the outpatient setting that were clearly documented and accessible in the EHR. But I think we all know that that happens pretty rarely in our space. I will say, again, just trying to be practical in my practice, I see a lot of patients with stage C heart failure who are doing great on medications. They feel well, and these are not the patients that I'm prioritizing for goals of care conversations. It's really when patients start to accumulate these indicators of advanced disease, worsening kidney function, escalating diuretic needs, et cetera, that I really start to intensify my primary palliative care efforts. Because if you can start planting these seeds early for patients, as you know, it becomes a lot easier to have these more difficult conversations when you reach that crisis point. So, back to this patient, if I was the inpatient attending, I think my earliest conversations with her would not be about advanced therapies or her code status. They'd really be focused on trying to get to know her, understand what she understands about her heart failure and what matters to her in terms of her healthcare. And then, of course, I'd be assessing other primary palliative care domains like symptoms and caregiver support. And from what you've described, I'm not hearing a clear trigger to involve the specialty palliative care team if the primary team is comfortable and sort of has the skills to handle these discussions.
I want to highlight something you said that I think is so important. And that's that so often when people think about palliative care, as you talked about when you're introducing primary palliative care, is there's often this conception that it's about immediately having goals of care discussions or end of life discussions. And really, when you're first meeting a patient who you've never met before, you don't know what their prior conversations have been. Like you said, in a perfect world, we would have a great documentation of conversations they've had in the past, but it's pretty unlikely that it's there if those conversations even have happened. And sometimes we hear palliative care and we think, okay, that means we're going to jump into this major goals of care discussion. We're going to have code status changes. We're going to do X, Y, and Z. We're going to have a really clear trajectory of what their overall care is going to be. When if you skip that basic step of getting to know the patient, getting to know their background, getting to know their goals and values, and really mapping out what's most important to them, you're not going to be able to have that conversation effectively. So I think that's so important. And I just wanted to double down on highlighting how important it is to do that step first and not get ahead of ourselves and think that everything has to happen in the first conversation, because you can tell from this case that she's going to be in the hospital for a good bit of time. So you have plenty of time to get into more of the nitty gritty on logistics of planning for what the next steps in our care will be.
Yes, we tend to be very goal oriented in cardiology. And I think building trust with patients early on really facilitate these bigger discussions that you're going to have later. So try to take a breath, take a step back, and as you said, really just get to know the patient in this early acute stage.
Yeah, thank you both so much for highlighting that. I think you did a really good job highlighting this misconception that I think a lot of people have of palliative care being very focused on end of life care. But with this patient, as Alix mentioned, she's being considered for advanced therapies. And so I wanted to ask, what role does palliative care play in a patient's evaluation when they're being considered for advanced therapies?
Yeah. So, as I mentioned earlier, there are several domains that fall under this umbrella of palliative care. But when we're talking about advanced therapies like LVAD or transplant, the focus really becomes on the decision making piece. And specifically, we really want to get into this shared decision making, which is defined as a collaborative process where patients and clinicians work together to make medical decisions that align with the patient's goals and values. So, just focusing on an LVAD here, because you noted that she's smoking, and there is a little bit more data on palliative care and LVADs, or a little bit more conversation around it. So, the decision to pursue an LVAD is one of the most high stakes decisions we make in cardiology. I mean, this is a major surgery. It has such profound implications for quality of life, survival, treatment burden. And it's actually one of the reasons I went into heart failure was because I was just so fascinated by how physicians and patients approach this decision, given all of the emotional and medical complexity. And I still am, honestly. But because of how weighty this decision is, CMS, or the Centers for Medicare and Medicaid Services, actually issued a mandate in 2014 that said that all patients being considered for destination therapy LVADs have to have access to a specialty palliative care consult to support shared decision making. And so fast forward to 2025, and we actually know that this policy has become a little bit confusing in practice for a few reasons. So first, the terminology has changed, right? We should not be using bridge to transplant and destination therapy anymore because transplant candidacy is so fluid. Patients move in and out of eligibility. And under the current UNOS allocation system, this complicates these labels even more. So that's number one. And then second, the wording of this mandate is very vague. And we've actually done some research showing that institutions actually interpret it very differently. So we did a survey of HFSA members at different institutions nationally, and we found a lot of variability in terms of how specialty palliative care is involved in the LVAD evaluation process and when. And actually, one of the first research projects I did as a resident was to look at all of our pre-LVAD palliative care consults at Northwestern. And I really wanted to understand the quality and the content of these consults. And we actually found that in many cases, these consults were just a checkbox. They were occurring very late, sometimes the day before the LVAD was scheduled, long after the decision to pursue the VAD had already been made. And as you can imagine, these consults were not meaningfully engaging in goals of care or advanced care planning. So I think this is a really good example of how a well-intentioned policy just doesn't always translate into patient-centered practice. So I personally think that if your specialty palliative care team is not familiar with LVADs, there are some places where palliative care and cardiology and heart failure are very integrated. And there are some places where palliative care is very focused on oncology. So if the specialty palliative care team isn't familiar with LVADs and if they don't feel like they're integrated, if they think they're just helping to fulfill a checkbox, their involvement may not be that helpful. It might even be harmful. If your VAD is scheduled for tomorrow and someone comes in and is asking you if you really want this VAD, you might be a little bit confused. I think on the flip side, if you have a heart failure or LVAD team member who's trained in serious illness communication and shared decision making, that can be incredibly valuable because they really understand the nuances of this decision. So at our institution, we have developed a model where a small team of heart failure clinicians with additional training in palliative care sees all of our LVAD evaluations. This was the program that I worked to develop. And this is just one model, but it's worked really well for us. And I think it really meets the needs of patients in our larger team.
I think that's such a great point about the thoughtful utilization of when to involve the palliative care team. And like you said, sometimes that comes harder because of policies that are made that push things in one way or another. But I think the real benefit of palliative care, just like you said, is when you've had a relationship with the patient or have a good understanding of what they're doing. And so I think the program that you've developed sounds amazing and something that I hope other places can model. So as we move through the process of advanced therapies evaluations, sometimes we realize that advanced therapies may actually cause our patients more harm than good, or maybe the patient themselves, as they learn more about the process, maybe an LVAD or a transplant, is unsure if they want to proceed with these therapies themselves, even if they are a candidate. What framework do you use to understand the goals and values of your patients to help determine how to proceed in these situations?
So the key there is framework. So I think having a framework for these kinds of conversations is just essential. And many people in the palliative care space draw parallels between communication and procedural skills, right? You wouldn't perform a right heart catheterization or an AFib ablation without formal training and maybe having done some simulation. And the same principles apply here. Goals of care conversations are high stakes, complex clinical interventions, and they really require a structure with practice and feedback, I think, to do well. So I've mentioned it a few times, but I use the Serious Illness Conversation Guide as a communication tool or framework to conduct my goals of care conversations. So the Serious Illness Conversation Guide is a communication guide that can be used to talk to patients about their goals and values, to share prognosis or break bad news, explore any other important topics, and make a recommendation. It is evidence-based, so it's been shown to improve the quality of serious illness or goals of care conversations, and it's available online for free. So check it out. I won't go through the guide itself, but one key point that we touched on earlier is that it really involves a lot of listening and probing. Something that I've learned from all of the palliative care clinicians that I work with is that we talk too much as doctors. We are so eager to give information and share data, but patients do not hear these things when they're overwhelmed. And they've actually done some really fascinating studies. In particular, one study of women with, I think it was metastatic breast cancer, showing that when patients receive bad news, they actually absorb or retain very little of the information that they're given in the moment. When you ask them questions afterwards and probe their retention, it's very low because there's so much shock and overwhelm. And they absorb even less, actually, when the clinicians are talking too much and when they're not displaying signs of empathy. So the guide really walks you through the types of questions to ask to try to get a sense of a patient's values and goals so you can help them make this big decision. There are other communication frameworks that are really helpful, I think, especially for high stakes decision making or breaking bad news. Many listeners have probably heard of REMAP at some point during their training. There's some subtle differences, but the overall concepts are the same. And then another tool that I find so helpful is best case, worst case. So this is a really powerful communication tool that's designed to help patients and families make medical decisions by visualizing a range of possible outcomes. And I think the reason this is so important in advanced heart failure is that we know from the literature that many people come away from these conversations about decisions thinking that their choice is the advanced therapy or die. And that is just not true. It's really a false dichotomy, even if you're talking about, let's just say, life expectancy only. I mean, patients can have a bad postoperative outcome after an LVAD and pass away, or they might be able to live a few more months comfortably at home getting best supportive care without an LVAD. So I think we really need to do better at creating true choice awareness because the choice is not the therapy or die. So the best case, worst case framework was developed by researchers at University of Wisconsin to help clinicians actually discuss high stakes surgical decisions. And there's a lot of instructional videos and examples of how to do this, how to map it out. But essentially, you outline two choices for the patient. For example, LVAD or best supportive care. And we have to name that as a choice, right? Rather than just calling it no LVAD. And for each of these choices, you outline on paper for the patient the best case, the worst case, and the most likely outcomes for the two choices that we're considering. And this is all based on the patient's medical situation, their risk factors. So it will look very different for our patient versus a 35-year-old without any comorbidities. So walking through this does take time, but it can be so helpful to really map this out for patients who are inclined to get into these kinds of details and look at what the different trajectories might look like. And we actually wrote a perspective in the Journal of Cardiac Failure on how to use this specifically for LVAD decision-making a few years ago. And so I think that provides a helpful example of what that looked like.
I think you said so many important things in that just resonate so strongly with me. I think the biggest thing that I think about all the time is just like you said, communication is truly a procedure in the way that we think about you wouldn't be cathing someone without ever learning how to do it. But I think there's just this major assumption that we know how to communicate because we've been talking to each other our entire lives. And there's just this assumption that we know what we're doing and everything's fine. But like you said, we have this inclination to just talk and talk and talk. And we love data and we love to give all the data and all the reason why we're giving it the information that we're giving. And oftentimes it's just so overwhelming. And I think we've all had that patient who's just repeating one piece of data that's like actually fairly irrelevant to their overall care, but they're just obsessed with one piece of information. That's what they took away from the conversation. So the more data you give, the more likely you're going to get into that trap where they didn't actually hear your headline, your take home message that you want them to remember. So I think it's just so important to really emphasize that thinking about communication like a procedure, thinking about what you're going to say and what your message is before you go into the room and really preparing and practicing, just like we said, whether that's simulation or making sure you're familiar with whatever sort of framework you like. You mentioned a variety of frameworks out there. I like REMAP. I love the Serious Illness Conversation Guide as well. And I think familiarizing yourself with those, see what actually feels natural to you, because you want to use a framework, but you also want to be yourself. So I think finding that balance and practicing is so important.
Yeah, I agree. I mean, I think someone that I used to work with likened this process of just giving patients bad news or breaking prognostic information as the patient's head or brain is like a snow globe, right? And you've just shaken it up and there's too much going on. And when we keep talking, none of that is absorbed. And I think a lot of times too, we're so concerned about efficiency. We're so busy. We're trying to get this conversation done and move on to the next patient. Actually, I think when we do more listening and less talking, it can make the conversation flow so much smoother. And I wish someone would study this, but I think if you do this conversation well, it actually probably takes less time. And so I think it's a great point that you made.
Yeah, absolutely. I have definitely found that I'm still not perfect at any sort of communication skills. I always feel like I'm practicing in every conversation I'm in, and I always come out with something that I wish I would have done a little differently. But with that being said, the more I've practiced, the more I've gotten used to this. I have found that when I listen more, when I use a framework, when I try to follow this pattern, the patient will kind of tell you what they want you to do. And then you can make a plan a lot faster than if you're trying to feed them information to get them to the plan that you want.
Thank you both. That's super helpful going into these conversations. As Alex sort of touched on, we do kind of assume we just know exactly what to say, but I think thinking about it in a more organized way is definitely the way to approach these things. So just kind of going back to our patient, after undergoing her advanced therapies evaluation, she is deemed not to be a candidate for transplant due to active smoking and is also not a candidate for LVAD due to significant peripheral vascular disease, renal failure, and right ventricular dysfunction. So for these patients who aren't a candidate for advanced therapies, palliative inotropes can offer some symptomatic relief and help with quality of life. What factors do you consider when deciding if a patient's a candidate for palliative inotropes?
Yes, this is such an important topic. I think even though we're offering LVAD and transplant to so many more people, we also have some data showing that our use of palliative inotropes is increasing over time as well. So we really need to be familiar with the risks and benefits of this therapy and the appropriate indications. So an important thing to know about palliative inotropes and what I always tell the residents is that there's no data demonstrating a survival benefit with these agents. There haven't been any high quality randomized controlled trials. There probably never will, but several well conducted observational cohort studies suggest that inotropes do not confer a survival benefit in advanced heart failure. Now, of course, you have to individualize this to each patient, right? There are definitely certain patients for whom I'm pretty sure an inotrope will help them live longer. For example, if there's a patient whose renal function just tanks when you withdraw the inotrope, possible, I feel fairly certain that the medication will improve that patient's survival. But on a broader scale, we don't have that data. So because there's no clear survival benefit, the main reason to use these medications is because they can help people feel better. Multiple studies have shown that functional status and quality of life improve for many patients on home inotrope therapy. Now, there are some risks to home inotropes. In particular, we think about infection, arrhythmias, and don't forget about treatment burden. And because of this, I really try to elucidate whether patients have symptomatic improvement with the inotrope. If they really feel no different when we've started the dobutamine or the milrinone, we really have to reassess whether this treatment makes sense for them. I also think this is one of those interventions where oftentimes, especially in cardiology, we just want to do something. When we know that a patient has a poor prognosis, we feel helpless that we don't have anything to quote unquote offer them. And I think it feels good to say, here's something that we can do. Here's something that we started. But if we start this therapy without really making sure our patients understand the indications, the risks, and the benefits, I think we're really doing our patients a disservice. And so another thing about inotropes is that I always attempt to wean them before recommending them for long-term use, unless I'm pretty confident that a patient will have significant undesired adverse effects if they're weaned. So for this patient, she has a persistently elevated creatinine, a high wedge pressure. I'm wondering if her lactate has cleared, but I'm wondering if she will become more symptomatic if we wean the milrinone or if her renal function will worsen. And wean still may be appropriate in those scenarios, but it just really depends on the patient's goals. And then finally, whether you involve specialty palliative care in the care of these patients, again, really depends on the culture and the experience of both the heart failure and palliative care clinicians at your institution. Because we know that life expectancy for patients on palliative inotropes likely ranges from 6 to 9 months for all comers, the consensus is to either involve specialty palliative care or really to intensify your primary palliative care effort, depending on where you are.
Thank you so much. That's really helpful to think about that way, and being a palliative specialist focusing more on symptom management and helping patients feel better as opposed to a necessary mortality benefit. There are a number of patients, I think, who are deemed unlikely to benefit from advanced therapies and have a poor prognosis and may even be appropriate for hospice care. And even if conversations suggest that hospice might best align with their goals, I think hospice can still be a very scary word for these patients, often informed by prior experiences with their loved ones. So how do you approach this idea of hospice and approach that subject with them when you have these conversations?
Yes, I love talking about hospice and heart failure. I think it's one of the areas that warrants a lot more study, but I think where we can really make a big impact in terms of research and advocacy and policy. There are definitely patients for whom, as you said, the word hospice evokes a lot of fear and emotion. And so there are a few things that I keep in mind when I'm broaching this topic with patients. First, this seems obvious, but the patient's goals have to be aligned with hospice. This is, as an aside, similar to when we discuss code status with patients. If we recommend a do not resuscitate to a patient, but this is not aligned with their goals, that's really going to break the trust with that patient. And so the same thing goes with hospice. If you've had a long conversation with the patient and they tell you they are prioritizing longevity over symptom improvement and that they don't mind coming back to the hospital for treatments, then hospice is probably not within their goals. And so you should not even mention it. On the other hand, if you have someone telling you that they want to be home with their family, they hate the hospital, they would trade being at home to having more time, then yes, this might be a good fit. So once I feel confident that a patient's goals are aligned with a comfort-focused approach, I will often summarize my understanding of their perspective, and then I will ask if I can make a recommendation. And I always ask if I can share information because I don't want to catch anyone off guard. And then I will say something like, given what you've told me, I wonder if it makes sense to set you up with a service that we often use for people who are living with serious illness towards the end of life. And then I will describe it. This is a team that includes doctors, nurses, social workers, and chaplains who come to your home, help manage symptoms, support your family, and really focus on making each day as comfortable and meaningful as possible. And then after I've described it, I will say this type of care is called hospice. And I have just found that when you lead with the description of what hospice does before you name it, people are much more receptive and you avoid that immediate shutdown that can happen when you lead with the word hospice because of that stigma that it can unfortunately still carry for a lot of families.
Yeah, I think that's super helpful. And I know you sort of alluded to this, but I think symptom management for heart failure and hospice can differ quite a bit from typical hospice management for patients with dementia or terminal malignancies. The use of diuretics for dyspnea management is one of the most obvious differences that's sort of coming to mind. Do you ever work with hospice agencies to sort of give guidance on symptom management?
Yeah, this is another one of my favorite topics. I think hospice is wonderful in so many ways, but we also know that the hospice care model was really developed to support patients with cancer and not necessarily patients with these chronic non-cancer illnesses like heart failure or COPD or cirrhosis. And I think the comfort level of hospice staff and teams often reflects this as well. We're really good at taking care of pain and nausea in hospice, but I think we're less capable of managing edema, ascites, and volume overload generally. And I remember as a resident, I would get so frustrated when we know that in heart failure, a good number of patients who enroll in hospice actually discharge themselves from hospice to present to the emergency room for acute symptoms that are usually related to volume overload. And as a resident, I used to get so frustrated by this, but it makes sense. If you are having symptoms that aren't being well controlled at home, why not present to the hospital to get an IV diuretic? So I think having that understanding gives us a lot more empathy and compassion towards our patients. But when it comes to heart failure in hospice at the end of life, I think there are a few other things to keep in mind. So the first is that care, of course, needs to be individualized. So our team, our Compass team, does interface a lot with hospice agencies because if heart failure is the primary problem and the patient is dying of advanced heart failure, it's nice for them to hear from the heart failure clinical team that's taking care of the patient. And I think it really helps to give them a clear handoff. And this should include your clinical expectations and guidance on what medications to stop or continue. Along those lines, I think it's important to remember that GDMT is palliative, especially the RAS inhibitors and SGLT2 inhibitors. And so if the agency is willing, we advise that they continue these medications if they're being well tolerated until they can't take oral meds anymore. And if the ARNI is too expensive, then you can suggest that they switch to an ACE inhibitor or an ARB, which might be cheaper. The third thing, as you alluded to, is that diuretic planning is really important. Most hospices rely on oral medications. Very few provide IV diuretics at home. So it's good to clarify what's available and give anticipatory guidance in that way. And then finally, I think it's a common misconception that once a patient enrolls in hospice, they have to stop seeing all their doctors. This is not necessarily true. If the hospice agency agrees and it's part of the care plan, patients can potentially continue to see their heart failure clinician through either telehealth or in person, especially if that clinician is helping with symptom management and helping to keep them out of the hospital. It does require some coordination and clarification about billing, but I do think exploring that as an option is really key here because it might be more beneficial for the patient to continue to follow with the heart failure clinician than their primary care, for example.
I think you brought up so many good points about hospice and the way that we need to partner with them as the cardiologist as well. And it's really not just handing off your patient to hospice. It's really complicated. And one of the experiences I had during my palliative care fellowship was getting to go to home visits with hospice nurses and getting to see how they manage patients. And they're taking care of so many people. They're getting a lot of different calls. And hospice, as you said, was set up predominantly for patients with malignancies or Alzheimer's, and the symptom management was a bit more straightforward or streamlined in that you're treating dyspnea with opioids or benzos because it's generally air hunger and that's what they're treating. And diuretics don't always come up in their algorithm, even though they have amazing experience. That's just not the thing that they're seeing most frequently. So I think I had similar experiences as a resident where I would wonder, like, why is this patient coming back to the hospital who we discharged on hospice for diuretics? But quite frankly, diuretics are making them feel better and it's not in the normal algorithm of hospice. So the most important thing we can do, I mean, it goes back to just we're communicating with our patients, but we also need to communicate with our outside providers and the hospice agencies that we're working with. And I think the point that you highlighted about the fact that you can still find a way to see your patients even when they are in hospice is so important. Because on top of helping manage their symptoms, that you're also a person that they had a longitudinal relationship with. And I've had patients say in the past that they didn't want to pursue hospice because they didn't want to stop seeing their doctors and they didn't want to lose that connection that they had that's been really meaningful to them. So I think being able to do that thing really serves two purposes. One, helping with the symptom management, and two, keeping up that relationship with someone who's been with them for a really long time and you've been with them through this entire disease trajectory. And I think it's really amazing to have that sort of meaningful relationship where someone wants to be able to keep seeing you even through all their end of life care.
That was great.
Let's go back to our patient, Miss HF. She goes home on inotropes, but she's continuing to struggle with volume overload, resulting in 3 hospitalizations in a 6-month period. Given the end-stage illness, the team has a goals of care discussion with her. During the conversation, she voices that being hospitalized over and over again is frustrating, but she isn't interested in giving up, and she still is really hopeful that her heart will recover with time. Some patients with end-stage heart failure may not have advanced therapies options, but still aren't ready to transition to hospice. You brought this up earlier when we were talking about hospice, and that bringing up hospice when a patient goals and values don't align with hospice at that time really isn't helpful, both in that it erodes the relationship and it's something that might make them have mistrust in you as their medical team because it doesn't seem like you're hearing them if you're bringing up something that's clearly not involved in their values. I think I see this frequently in patients who are still receiving a lot of symptomatic benefit from their admissions for IV diuresis. Other times, patients are still hopeful for a cure or miracle. I know the situation is really challenging for me throughout my general cardiology palliative care year, still now. And it's very hard to navigate these kinds of situations. What personally do you do in these situations when they come up?
Yes. I too remember being a trainee and still I find these situations really challenging. And I think it's helpful to first start with some introspection and ask why this feels so hard. So here we have a patient with advanced heart failure who's clearly declining. She doesn't have any viable life-prolonging treatment options. And yet she's telling us that a comfort-focused approach doesn't align with her goals. So why does this create so much tension and even some moral distress for us? So I think moral distress comes up when the course of action that we're taking feels misaligned with something about our ethical values. So maybe we feel like we're not effectively conveying the seriousness of her prognosis to her. Maybe we worry that repeated hospitalizations aren't the best use of resources, especially with the pressure that we always feel to free up hospital beds. Maybe there's some implicit bias at play, or maybe this just isn't what we would want for our own loved one, and that's upsetting. And I think there are 2 concepts that have really helped shift my perspective in these situations. The first is this idea of prognostic awareness. So this is the process by which patients absorb information about their prognosis at a pace that feels tolerable and that allows them to keep functioning in the world. So if I was diagnosed with metastatic cancer tomorrow, I don't know that I would be able to walk around really carrying that reality right away. So what we sometimes label as denial is often, I think, a self-protective tool. And it's just a way that patients gradually and safely integrate reality into their worldview. And some people have written about this and described prognostic awareness actually as a pendulum that sort of swings between realism and hope. And that can even happen in a single conversation. So I feel like I'm remembering a patient who I was talking about how I was worried there wasn't much time left. And they sort of acknowledged that time was short and that they might be dying. And then in the next breath, she said she couldn't wait to go to Hawaii next year. And so I think this is a normal part of coping. Second, a little bit less eloquent, and we've touched on this a few times, but I think we just cannot force patients onto our timeline. And I'll say it again, we've all seen this. We see a patient who's dying. We suggest a shift towards do not resuscitate or comfort-focused care, and the patient or family kind of shuts down. They lose trust in the team. They dig in their heels, and that is really because we pushed them before they were ready. And so instead, I really think we need to take our cues from the patient and just support them as they come to terms with their illness. And this can be gradually, and it just has to be at their own pace. And I really think that understanding these things has helped me mature so much in my approach to these kinds of patients and has really lessened the frustration that I would feel that you articulated before.
Yeah, I think that's such a great way of thinking about it and taking a step back and really making sure you're processing and understanding that this is normal human behavior, to not be ready to accept maybe the reality that you're in. Dying is scary. The possibility of dying is scary. And it's totally normal to not be ready to take that in right away, no matter how long you've been having your whatever illness you've been living with. I think the other thing you brought up is really important. And we've harped on it a couple times about not forcing people into your own timeline. And I think we actually hit on this a little bit early on when we were talking about why we like to give information, why we like to jump straight into things like code status and plan. We really love outcomes and we love to have a plan and we love to come up with what we're going to do next. And I think a lot of times when we go into a goals of care discussion, we evaluate how successful the goals of care discussion was based off what the outcome is. And often that's an outcome that we came up with before we went into the room. So maybe we're thinking this patient is dying, they need to go home on hospice. And if the outcome of our goals of care discussion isn't the patient going home on hospice, we feel like we've failed. So in my head, what's helped me with this is really changing my framework of how I grade a goals of care discussion for myself. The two things that I'm really trying to accomplish when I go into a goals of care discussion is one, making sure I'm giving the patient clear information. And I want to know that they heard the information I'm giving. So what am I saying about their prognosis? What do I think will happen next? And then I want to make sure that I responded appropriately and supported them with whatever reaction they had to that news that I gave them. And if I'm able to accomplish those two things, I can take that as a success, regardless of what the outcome is with regards to code status or disposition with hospice, or if they're going to continue with aggressive care and repeat hospitalizations. I think that's a way that I can take my own opinions on what I would do if it were me or my family member. It helps me take that out of it and instead just focus on what I have control over in the conversation, which is being a good communicator and being a supportive doctor.
Thanks, Alix and Sarah. I also think it's really important to acknowledge, as we had kind of touched on and skirted around, but the fact that as providers, we will have emotional responses. And this will be emotionally draining sometimes. And it will be really hard for us to watch our patients struggle and hope to support them in any way we can. But I always think it's really important, especially as I was kind of going through a really intensive training year last year when I was constantly on service and constantly having really sick patients die, because I was fortunate to train in a place that likes to give patients a chance, even though they're high risk. And I think just acknowledging that for the providers, it can be really emotional as well. And also having my frame shift that helped me was, how do I help this patient, if I do think they're dying, die well? And I don't define that. The patient defines that. And sometimes the patient likes to go out in a ball of flames. They like to know and have their family know that they've done everything that they medically can. And the result is them dying, but they have peace and their family has peace from that. And maybe that's not what I would want for my partner or myself or my kids, but it's what they want. And so that gives me less emotional distress in those situations. And I think that it's important to acknowledge that in this amazing field of heart failure, we do have to help people die well often. And so these conversations are so important for that reason. Another patient population that I really have fallen in love with and have learned a tremendous amount from is our adult congenital heart disease patients who have developed advanced heart failure. So I'll say that again for listeners who don't think about this often, because it's two different things. So patients with congenital heart disease that have grown into adulthood, And we're so fortunate that that patient population is growing because of amazing advances in that field. And then they develop advanced heart failure. So a particular patient I'm thinking of, and I'm going to talk about anatomy and it's going to be okay because we're all going to understand. But a particular patient I'm thinking of, she's 25. She was born with double inlet RV and she had a Blalock Taussig shunt, a bidirectional Glenn, and the end result, which our listeners are likely familiar with, is a Fontan. And that was complicated by early cirrhosis because we know that these patients with Fontans have pressure that builds up back on their liver and that will cause cirrhosis over a period of time. So for our cardio nerds who don't love thinking about this anatomy, I'll simplify it for you. Her venous blood drained into her lungs via the Fontan. And then from her lungs, the blood went into her systemic RV, which then sent the blood out to her body. And unfortunately, that systemic RV was failing because it's not built to deal with systemic pressures. So thinking about advanced therapies, again, I was really fortunate to train at a center that will consider transplant in these patients. But given the high complexity, they're often not transplant candidates. Dr. Chuzi, this is such a unique patient population. So how can palliative care help this patient and her family navigate her illness? And I think particularly unique to this population. How do you navigate the reality that this patient and her family have likely been told that she is going to die over and over and over again, and every time she's proven them wrong, and that causes her to have a certain mindset? So I would just love to hear your thoughts on that.
Yeah, it's great that you love the adult congenital population. It's certainly very complex medically, sometimes psychologically and emotionally, and they really need good care. So I think you're really getting at two important concepts here. The first is that among patients with heart failure, there are some very unique subpopulations who may have different perspectives and needs because of the journeys that they've been on. And I'm thinking about specifically adult congenital heart disease, but also patients who've had LVADs and those who have undergone transplantation, right? All three of these subgroups have been through a lot medically, emotionally, and often over many years. And so when it comes to palliative care or shared decision making, you're right. I think our approach might need to look a little bit different than it does for patients with more typical heart failure trajectories. And then second, as you mentioned, patients with adult congenital heart disease in particular tend to be very resilient, and many have survived multiple surgeries and complications. Some have been told, as you said, more than once that they might not make it, and yet they're still here. We can only imagine how traumatic that must be for patients and their families to be sort of repeatedly facing their mortality, especially from a young age. And that can shape how they think about their prognosis and their worldview. And I think there's kind of a protective layer that forms that's very understandable. This is psychological survival. So I've learned a lot actually from Jill Steiner, who's at the University of Washington. She's an adult congenital heart disease specialist and a palliative care researcher. And she talked a lot about the importance of integrating early advanced care planning and goals of care discussions for these patients, really with a focus on the psychological symptoms and the coping aspect. And she also likes to remind us that in this space, palliative care is not just for Fontan patients. I think that's what we think about all the time. But the heterogeneity of adult congenital heart disease is big. And Fontans certainly benefit, but there's so many other patients too who would. So for a patient like this, I hope that she's already had some advanced care planning conversations with someone she trusts and really someone who's helped her flex that muscle of prognostic awareness over time. But even if she hasn't, I think there are some meaningful ways to open this door. So one strategy or phrase that I found really powerful and effective to meet the challenge that you've said, which is that maybe they don't believe you if they say that they're sick, is to say, I'm worried this time is different. And then you sort of explain why this might be different than the other times when she's miraculously pulled through. And of course, you have to leave space for the possibility that she might not believe you right away. And that's okay. We have to take that pressure off of ourselves. And I think just creating that opening and building that trust in the moment can go a long way and set the stage for future conversations.
One thing that you said that I think applies to all patients, not just adult congenital patients, is that the patient had heard numerous times that they were dying. And I think we hear that in all sorts of populations. It's obviously more prevalent in these ACHD patients who have living with their disease since they were born. But I think it's somewhere that we can be careful about our language because we obviously want to be honest when we are worried that someone is dying, but phrasing it in a way that we say we're worried and leaving the possibility open for recovery is important. Because I can think of so many times where someone was like, well, some doctor told me I was going to die 6 months ago, and that was 5 years ago. So why should I believe you now? And so you can recover from that with things like Dr. Chuzi said, and saying things like, I'm worried this time is different and this is why. But it just requires a little bit more work because they already have this mistrust based off what they've heard. And I think that's somewhere that practicing communication and practicing delivering this kind of news is important and comes into play, because you can give your concerns, you can share what you're worried about with prognosis, but people do make miracle recoveries at some point that we don't expect them to do. And leaving a little bit of space for the unexpected, even when we are delivering this news, can help any future physician having these conversations as well.
Yeah. And let's be honest, we in heart failure are not good at prognosticating. They're very good at it in oncology. And maybe one day soon, AI will solve all of our prognostic mysteries of the world. But we have to be very humble when we're talking to patients about our expectations.
Well, this has been so much fun getting to hang out with some of my favorite people and talk about one of my favorite things. So as we wrap up, Dr. Chuzi, what are your main takeaways for cardio nerds?
I have a few. The first is palliative care is not just for the end of life. Hopefully, I've convinced you of that. It is about relieving suffering. And this is something that all of us in all fields of medicine hopefully want to do. And I think we as heart failure clinicians can make a really big impact by intentionally honing some very basic skills. The second thing is that patients have choices when they face these decisions about advanced therapies. And I think it's very important to promote this choice awareness. There are tools and framework out there to help you have these discussions with patients to make them high quality and effective. So I think we should be pursuing excellence when it comes to these conversations. And then finally, I think the field of palliative care and heart failure is such an exciting space. And there's so much room for especially younger trainees to contribute, not just clinically, but in terms of research and program building. And so for listeners, if this is something that you're interested in, please reach out to me and follow your passion. And don't let anyone tell you that this is not a field that's worth pursuing.
I really have to echo what Dr. Chuzi said about this exciting space for anyone who's interested in the intersection of cardiology and palliative care. I can't tell you how many people said why when I told them I was going to do these 2 fellowships. And I use my palliative care training in cardiology every single day. So join us. We have a fun group of people. If you're interested, reach out to any of us. We'd love to talk with you more about how you can get involved in our community.
Yay. Thank you both so much. This was so wonderful. And I too have an interest in palliative and heart failure. So I'm very fortunate to have met both of you and learned from you on this amazing episode. I just want to close by asking both of you, what makes your heart flutter about the intersection of palliative care and advanced heart failure?
What really excites me about palliative care and both cardiology and heart failure is that this is a way that we can really get a deeper connection with our patients. I was drawn to cardiology because I love all the advances that we can do, the interesting physiology, the cool cases we get to see. But what makes me love being a doctor is the relationships I form with these patients as I walk with them through their disease trajectory and prognosis. And I think thinking about primary palliative care as you do this is something that really deepens that relationship. And so it's something that makes me excited as we think about how we can teach other doctors to incorporate this into their practice.
I think the field of heart failure is so intense. And I think that's why so many of us were drawn to it, the intensity. And I think the thing that I've always loved most is just being there for patients during these incredibly profound moments where they're making these difficult choices and facing their own mortality. And I've just always thought it was such a privilege to walk alongside patients during their journeys and just be able to ease their suffering in some way, whether that's physical, emotional, existential. And I think this intersection is so important. And there's so much to do in terms of research and development. And so I'm just really excited to recruit more cardio nerds to this space.
Thank you, Sarah, Alix, Shazli. This is the completion of our initial planned, although we have some fun episodes we could talk on, Advanced Therapies series. And I'm so happy that we closed with this because I think it really highlights the wonderful aspects of heart failure. And it highlights the amazing intersections that heart failure has with so many other specialties. Alix was kind and joined us on a heart failure podcast, but she's a critical care cardiologist that's also done palliative care. And so you can see some of the really amazing careers that you can build and wonderful people that you can meet. So thank you, Sarah and Alix. Thank you, Shazli, for co-chairing this really fantastic, I hope, or at least it has been a fantastic experience for me, series. And I'm so thrilled to have you all here with us tonight. Thank you for your time.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Julia Marques. I am an intern in the CardioNerds Academy House Thomas, and I'm a 6th-year medical student at Albert Einstein University in São Paulo, Brazil. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.